My name is Rashmi Halker Singh. I'm the Deputy Editor of Headache. It's my pleasure today to be joined by Dr. Patterson Gentile, who's the Headache Fellowship Program Director at CHOP and one of the authors of a recent publication entitled The American Headache Society White Paper on Treatment of Post-Traumatic Headache from Concussion in Youth. So welcome. I'm so happy to speak to you about this really important publication with us today.
Thank you so much for having me. It's a pleasure to be here.
So, first of all, I was wondering if you could share with us why you all wrote this white paper. What was the need? Why did you all feel that this was an important publication and project to take on?
Absolutely. So this actually came out of working with both American Headache Society special interest groups for post-traumatic headache as well as the pediatric section. And really discussing with colleagues, many of us who take care of post-traumatic headache were running into the same challenges of there really aren't any written down guidelines on how guiding care of post-traumatic headache. Headache is the most common symptom following a concussion, particularly with regard to timing, what treatments have some evidence behind them, what are the knowledge gaps. And so we really wanted to gather all available information by combining this with a systematic review as well as expert opinion to provide guidance with the information we have now.
Yeah, I think that's really important. I've found really important things that I can take into my clinical practice from this piece. And I wanted to ask you about a couple of things from that. One thing that you all identified were that some individuals may have a higher risk for prolonged recovery from concussion, including some social determinants of health that may have an impact as well. And I'm curious, do you think that might change clinical practice? Should I be, screening my patients or counseling them differently based on those findings?
I do think that we should be asking these questions and being aware that they are risk factors for prolonged recovery. I think one of the big challenges with concussion is that most youth recover with standard guidance, whereas there are those who are at higher risk for prolonged recovery and particularly persistent post-traumatic headache. And this helps us identify who may need more aggressive treatment, more close follow-up to make sure that to try to improve outcomes and so that everybody recovers quickly from concussion. And so absolutely, there have been associations between adolescent age, female sex, and as well as other socioeconomic factors that can put you at a higher risk for prolonged recovery. And these are the patients we need to be paying extra attention to.
You also spoke about when to start preventive treatments in patients, and I was wondering if you could speak about that for a moment too.
Absolutely. So this was a big point of discussion. And I think this came out of that I, like many other headache specialists, at least when I started on this, I was seeing patients who had received really top-notch non-pharmacologic care for concussion, but they had oftentimes a continuous headache. They were presenting 6 months, 9 months, a year plus after their injury and had not received yet any headache-directed care. And there is also this sense that in concussion, prolonged symptoms involve not only biologic changes, but also complex interactions between biologic and psychosocial factors. And so the earlier we can treat and get somebody feeling better and back into their normal daily routines, likely the better outcomes they'll have. This is still an area we need more research on, but I think that there are some, particularly using things like supplements, which are low risk. There have been some small randomized controlled trials and used early in concussion that we can be starting these earlier to get individuals who need it more headache-directed care. And I think this is where you're really using the risk factors along with the available evidence we have can help us move care earlier. So headache is not the thing that is holding somebody back from a recovery.
Those are such important points. I mean, this is such an important time in an adolescent's lifetime that they'll never get back. And if we can intervene early, it can make such a big difference. I was really impressed by the amount of literature you all went through and the attention to detail in this paper. And I'm curious, as you went through all of this, did anything really stand out to you? Or, you know, what are some additional takeaways for clinicians that you might have that you didn't really think about as you started on this project?
Absolutely. So I think one really key piece that I ended up thinking a lot about, and I think all of us did, is so first of all, this spans beyond the headache specialists. Headache specialists are really the ones getting involved later in the course in a lot of cases. And and so spreading this knowledge to you know, our sports medicine and emergency department colleagues, and offering treatments that a broader range of clinician can be comfortable with. So this includes non-steroidal anti-inflammatories, and proper use of those supplements, and then also really when to refer to a higher level of care, more headache-directed care for prescription level pharmacologic management as well as multidisciplinary care. I think so that I think is one of the biggest takeaways. The other one, just there were a couple of discussions I think that came up that I also think are worth pointing out. So one is the use of non-steroidal anti-inflammatories to begin with early in concussion. So as headache experts, many of us felt comfortable even when we had a patient relatively early on, but there was this concern from that stemmed out of emergency department and sports medicine communities about the potential of worsening a cerebral hemorrhage, for instance, that was delayed, and so not really using those medications within the first 48 hours. Though there is actually a study that looked at this, and the rate of delayed cerebral hemorrhage after the first 6 hours from a concussion in youth was actually 0% in those who had no mental status changes following minor head trauma. And it was 0.03% for those who had mental status changes. So really, if you have a clinically stable patient with a minor head trauma, it's probably okay to use these medications. And there was even a pilot randomized controlled trial that suggests it might be helpful. And I think the other point that that came up in our discussions was the use of triptans early on. And this was one of the areas where there was debate amongst amongst the headache specialists, because triptans are vasoconstrictive, and there is mounting evidence that there's cerebral blood flow changes that occur particularly acutely within the first week to month following a concussion. And so there were some hesitancy and concern without additional safety data from some about using these medications really acutely following concussion, whereas there are others who are very comfortable, particularly if it was to treat migraine-like headache in a patient who had already had migraine and tolerated these medications. And so this was a really interesting point that I think really requires further study. And I think it's worth pointing out that there's a even disagreement among experts about the right course for this.
Wow, I really appreciate hearing all that backstory because it shows how much thought and attention to detail went into these recommendations. Do you have any final thoughts to share with all of us?
I'm just so appreciative of the American Headache Society special interest groups of post-traumatic headache and pediatrics for supporting this study, and for my co-authors who really made this just a very enlightening experience for me as well. And I'm excited for the attention that this work is getting.
All right. Well, thank you so much. It's a pleasure speaking with you today.
Thank you.